مني احمد القشره كمان شويه. الفينستريتد او البرانشد للشورت نيك او الجاكستارينال. بالمناسبه اول فينستريتد جرافت اتعمل ما كانش فيه بريدجنج ستنت، وكانت سليت بس مفتوحه كده على ايزوليتد رينال. بعديها جت روي جرينبرج عمل البرانشد جرافت، وبعدين 2001 بعد سنه 2000 دي جه الإلياك برانش. ده تطور الستبس اوف ديفلوبمنت ان اندو ريبير اوف اورتيك انيوريزم، وبعدين الفينستريتد جرافت. طبيعي لما يظهر حاجه جديده مؤكد ان كل النتائج هتبقى في صالح الجديده، فنشوف النتائج دي كلها يبقى الزينس جرافت السيف اند افكتيف. مش كده وبس، بعد 5 سنين ما زال زينس فينستريتد جرافت از جود اند افكتيف. هو في مشاكل للزينس ولا ملوش؟ له، وهنشوف دلوقتي ازاي. البارارينال والبي برانش. نيجي للسوراكو ابدومينال، نطلع فوق شويه، ما بقتش مشكلتنا عند الفيسرال اريا، بقى من فوق لتحت. احنا تقريبا خلصنا الوقت. طيب ادوني دقيقتين هقول بسرعه اللي انا عايزه. في السوراكو ابدومينال اورتيك انيوريزم قلنا البروبوزلز يا اما فيزيشن موديفايد ديفايس، كوكتي برانش، جورتامبي، مترونيك، كاستم ميد ديفايس. طيب كلكم عارفين الكلام ده، لكن عايز اوصل لنقطه التشالنج بتاع الفيزيشن ميد فينستريشنز، انه الريبورت كلها كيس ريبورت واوت كمز، لكن ما فيش ستاندرد ليها، ولما تتعمل ملهاش كواليتي كنترول، ما اقدرش اقول ده اتعمل صح ولا غلط. زائد انه الوقت اللي بتعمله اللي بتاخده في الفينستريشن بكل برانش المفروض او كل ارتري ياخد 18 minutes، يعني لما تحسبها تبقى ساعه وشويه. نكمل عشان اما يبقى فيه راديشن في بروسيدير طويله يظهر الريسك اوف راديشن انه ممكن يجيب كانسر ويجيب الفيكتيمز بدول. فحلها انه نعمل فيوجن ايمجنج تكنيكس عشان يبقى سهل الكانيوليشن، او الفورس او الفايبر اوبتيك ريال شيب، ده ما فيش راديشن خالص، والديفايس اورينتيشن بيبقى على الماشين بره، تقدر تكانيوليت كل ارتري لوحده. الحقيقه لما نبص للكلام ده نلاقي لسه في مشاكل كتير ما اتحلتش، ده غير البريدجنج ستنت بتاع الفينستريتد او البرانشد جرافت، فيها مشاكل كتير جدا. اذا الفيوتشر مش لسه جاي، احنا دلوقتي فين؟ the future is now. احب اقدم لكم صديقي الدكتور احمد القشره. His presentation will be about hybrid debranching endovascular aortic repair, pitfalls and the status in endovascular era. بالمناسبة أحمد القشرة اشتغل في مصر وبره مصر، وكانت رسالته على الدي برانشنج. الدي برانشنج it looks nice at the beginning، لكن during follow up هتلاقي أحمد يقول لنا ليه ما كملناش عليه.
Great thanks for Professor Dr. Nasser Saeed and Professor Megdi Hagek for the kind invitation. My presentation will address the pitfalls and the status of hybrid EVAR in total endovascular era. Level 1 evidence for early survival benefit from EVAR is well established, and not only early survival, but 5-year survival and freedom from re-intervention over 5 years is to the side of EVAR over open repair. However, the situation in thoracoabdominal aortic aneurysm is different because open repair has the challenge of two cavity exposure and aortic cross clamping, mechanical circulatory support, and thoracotomy. All of this can morbid the patient. So we should search at this time for new options. One of these new options is hybrid branching EVAR that was first described by Professor Kenneth Baldrich at University of California, who address hybrid branching EVAR in one stage or two stage procedure. First step is to do visceral debranching of visceral vessels, then fix the aneurysm through EVAR to avoid thoracotomy, aortic cross clamping, into cavity exposure, and circulatory bypass. However, there were conflicting results of hybrid EVAR lead to criticism and ambiguity of this approach, especially with fast evolution of EVAR toward total endovascular repair in the form of fenestrated custom-made technology, and the availability of T-branch, which is off-shelf multi-branch device. From now, I will talk about my experience at Hamburg. It's a retrospective analysis data over 4 years, including 33 patients. You can see in this table how the surgical risk in this patient in the form of cardiovascular risk factors and the previous intervention in most of the cases. Added to that, the urgency and emergency of the cases in the form of symptomatic and ruptured case, which account for 21 in ruptured aneurysm. Here is an interesting case in which the patient developed aortic dissection and was acute subacute stage and presented in the chronic stage with thoracoabdominal aortic aneurysm without any intervention, in which all visceral vessels come from the compacted true lumen. So we think that if we did the branching of the 4 visceral vessels dependent on flow from the iliac, and then deploy the stent graft not in the true lumen, but in the false lumen, because false lumen perfuse the extremity. So we did hybrid EVAR, but now in this case, we deploy the stent graft inside the false lumen, because in chronic stage, it's fibrotic and can withstand landing stent graft. Another case in a Marfan patient who did previous thoracic aortic repair and developed years later batch aneurysm. And this aneurysm were successfully fixed through hybrid EVAR. As you all know, there is a lot of configuration of the visceral debranching bypasses, and maybe also we can do transposition of celiac artery over superior mesenteric artery or splenic. And also the inflow site vary from iliac artery or iliac graft or infrarenal aortic graft. All configuration are accepted. Late in this study, we include some cases with Gore hybrid graft to decrease the time needed for anastomosis to the renal arteries. From now, I will talk negative about the outcome. 6 patients who did visceral debranching died before completing the procedure with EVAR due to multiple causes like multi-organ failure, aortic rupture, and septic shock. And also, 5 patients who completed hybrid EVAR were died for major stroke, cardiac arrest, aortic rupture, and multi-organ failure. So this nice picture during the procedure ended with this in about 1/3 of the patients. Also, the early morbidity were high because with spinal cord ischemia, 3 developed pneumonia, 4 developed respiratory failure, 2 thoracotomy, and 4 patients developed dialysis, and 4 developed mesenteric ischemia. So there is high morbidity and mortality as regard the Hamburg data. Also, early CTA were not nice because 3 patients developed type 1 endoleak and 2 patients developed type 3 endoleak. Here is an example of type 1A endoleak in one patient that was fixed with proximal TVAR stent graft. During the follow-up, 9 bypass grafts were included and were received treatment through thrombectomy, except one limb for right renal artery in patient with dialysis, and one celiac artery was reperfused through stent via retrograde access using Vibrant, as addressed in this illustration. Also, during follow-up, 5 patients developed endo leak. 2 of them with type 1 were fixed through proximal extension, and 1 with type 2 endo leak with sac enlargement were embolized through transcaval approach using coils and glue. In rapid search of literature, also there were high morbidity and mortality in all single center study as addressed in this table. So if we revised our data in Hamburg with this data and literature, it's not far away as regard high morbidity and mortality. So the open question of this presentation, what is the status of hybrid EVAR at endovascular era? Especially with increase the complexity of procedure of fenestrated and branched EVAR and increase the number of fenestration with increasing the learning curve and decreasing procedure time, radiation, and complication. To answer this question, we did an effort to revise the preoperative CTA for patients who received hybrid EVAR for the stability of branched and fenestrated EVAR, and found that most of the patients are candidate for branched EVAR, fenestrated EVAR, and the combined fenestrated and branched EVAR. Only 3 patients that account for 10% can't be candidate for total endovascular repair because of massive kink, and in another patient, both renal artery were included with triple barrel dissection, and in one patient, the mesenteric artery originated from false lumen at severe acute angle. Sorry. So now at Hamburg, the hybrid EVAR are limited for some patients with genetic aortic syndrome, some patients with unfavorable anatomy, and in urgent cases with no feasibility for off-shelf stent graft. We should keep this in our mind that no one size fits all. We should keep an advanced aortic center open, hybrid, branched, and fenestrated EVAR. Based on this data and the revision of literature, we can conclude that hybrid procedure have several advantages over conventional repair. We can conclude that hybrid procedure have several advantages over conventional open repair. However, the patient selection and weighing the risk factors and the anatomical criteria of individual patient to guide the planning for optimum procedures. In centers with easy access for fenestrated and branched stent graft, the hybrid EVAR still has a role in high-risk patients with genetic aortic syndrome and anatomical restriction for fenestrated and branched stent graft, and still future have a lot. Maybe spider graft in the future to change all of this. Thank you.
شكرا دكتور احمد. May I invite Dr. Amr Abu Rahma? He will talk about update on treatment options to obliterate false lumen in chronic aortic dissection.
بسم الله الرحمن الرحيم. Many thanks أستاذنا دكتور مجدي حجاج for his kind invitation, and many thanks Dr. Nasser for organization of this great conference. My presentation today about the treatment options to obliterate the false lumen in chronic type P aortic dissection. When speaking about aortic dissection, there are some well-established facts. One of these facts is that the management of type A, which involves the ascending aorta, is essentially by urgent surgical intervention, while the management of type P aortic dissection, which occurs distal to the left subclavian, is by medical treatment unless it is complicated. So if we have a patient with type P aortic dissection and this patient passed the acute phase and became chronic, logically, this patient will be treated by medical treatment. So what are the reasons to intervene in such a patient, and how to obliterate the false lumen, and which is the best time to intervene. All these questions will be answered during this presentation. But first, we have to define chronic. Historically, type P aortic dissection was defined as chronic when 14 days have elapsed from the acute event. And this classification was based on the fact that 70% of deaths occur within 2 weeks from the onset. But now we have a recent classification into hyperacute, acute, and a new division, which is the subacute from 15 to 90 days, and the chronic more than 3 months. The first question, why to obliterate the false lumen in chronic type P aortic dissection? Because continuous flow into the false lumen leads to aneurysmal growth and degeneration of the aortic wall with the risk of rupture. Also, it leads to collapse of the true lumen and even collapse of the stent graft. And it was found that false lumen patency is independently associated with poor long-term survival in chronic type P aortic dissection. What are the methods to obliterate the false lumen? Believe it or not, these are the methods to occlude the false lumen in type P aortic dissection, as we will see during this presentation. We all know that the treatment of type A is by covering the entry tear by stent graft. Closure of the proximal tear is efficient in acute type P aortic dissection, but it is not always sufficient in the long term, as after standard TVAR, complete false lumen thrombosis can be achieved only in around 40% of cases. So you will have now 60% of cases you need to obliterate the false lumen in these cases. To obliterate the false lumen, you will need to know how this false lumen is pressurized, how the flow is getting in and how it is getting out, what is the direction of the false lumen flow, antegrade or retrograde, and you have identified all the re-entries and the collateral origins. Moreover, in chronic aortic dissection, the flap is rigid, so reapposition is not easily accomplished. And it was found that better aortic remodeling is seen after endovascular treatment during the acute and the subacute status more than the chronic status. The procedures to obliterate the false lumen can be summarized into the following categories, either by direct embolization of the false aortic lumen, or by what is called the Betico and the stabilized techniques, and by occlusions of the collaterals and re-entries. Frequently, combined procedures are performed to achieve false lumen thrombosis. The first attempts to embolize the false lumen was described in 2003 as what is called the cork in the bottleneck strategy, using Kiva filters, detachable balloons, and different occluders into the false lumen. But there was limited efficacy of this technique due to the high aortic flow. Another technique to embolize the false lumen is the candy block technique. And this technique consists of the placement of a large occluder device into the false lumen, distally aligned to the true lumen stent graft, ending above the celiac trunk. Initially, the candy block consists with a back table modification of a 42 millimeter diameter Zenith thoracic stent graft by placing a central diameter reducing suture in the middle of the graft. And this will give it the shape of the candy rubber appearance. A second generation of candy plug was recently introduced with a self-closing central channel. It is different than the previous generation. It has a tubular appearance. This will increase its sealing capability. The suitability for the use of the candy plug mandates available access to the false lumen at the level of the iliac or infrarenal, and the sufficient extension of the dissection above the celiac trunk to accommodate the introducing system. Different to the candy plug is the Knickerbocker technique, which is an endovascular fenestration technique, and it does not require access to the false lumen nor additional materials to occlude the false lumen. Its application consists of expanding a compliant balloon at the level of a large diameter stent graft segment to rupture the dissection membrane at a limited segment of the aorta shortly above the celiac trunk. The shape of the diploid stent graft is similar to what is called knickerbocker trousers. دول كان الناس بتوع نيويورك زمان كان اسمهم النيكربوكرز، فكانوا بيلبسوا النوعية دي من البناطيل. Another technique is the BTCO technique. BTCO means provisional extension to induce complete attachment. ولكن لما نيجي ندور على الترجمة بتاعت البيتيكو دي معناها الاندر سكيرت اللي بيتلبس تحت الجيبة عشان يعمل لها extension، فسموا التكنيك دي بالبيتيكو. فin this technique, a scaffolding bare metal stent is placed for distal extension of a previously implanted thoracic stent graft. Further evolution of the BTCO is the expanded BTCO, in which stent graft in the thoracic plus additional distal bar metal stent into the abdominal and infrarrenal aorta, followed by parallel stent graft into the common iliac arteries. Another technique is the stabilized technique or stabilized concept. It is a stent-assisted, balloon-induced intimal disruption and relamination in the aortic dissection repair. It is a combination of proximal thoracic stent graft and a distal bare metal stent as in the BTCO technique, with additional balloon-induced intimal disruption of all the distal aorta. Another promising technique is the laser aortic septotomy, with technical success in about 91% of cases, with elimination of the retrograde false lumen in all cases studied. After showing all these complex procedures, the important question is when to intervene. As we all know, the main treatment of these cases is medical treatment. By revising the guidelines, there was no hard evidence on the preferred timing for the induction of false lumen thrombosis. And I will summarize this from the guidelines that the indication for repair in chronic type P aortic dissection is aortic diameter more than 55 millimeter, progressive enlargement more than 5 millimeter per year, recurrent symptoms or the development of acute aortic syndrome. So to conclude, false lumen patency is independently associated with poor long-term survival in chronic type P aortic dissection. Just 1 minute, please. Closure of the proximal tears is efficient, but it is not always sufficient in the long term, and you have to treat all re-entries and the collateral origin. There is no hard evidence on the preferred timing for the induction of false lumen thrombosis. And thank you.
شكرا دكتور عمرو. Another عمرو from القصر العيني, Dr. عمرو عبد الرحيم. He will talk to us about robotic and artificial intelligence in endo repair of aortic aneurysm.
Bismillah ar-Rahman ar-Rahim. I would like to thank Professor Nasser Said for his kind invitation to this conference, and my special thanks to Professor Magdi Haggag for his kind invitation. And as always, Dr. Magdi is the one who taught me the first steps in vascular surgery. My talk will be about the robotic and artificial intelligence in endo repair of aortic aneurysm. It's a kind of thinking outside the box. It's time to fly in the space. The human being reach outside our Earth to the whole space. So, what is meant by artificial intelligence? Artificial intelligence is that computed program which perform tasks simulating our brain, including identification, recognition, analysis, learning from past experience, problem solving, and decision making. There is different programs, which is one of them is the machine learning, which allows to uncover the patterns and to make decision from the available data without need for frank instruction or prior assumption. numerous algorithms can be used, and the machine learning itself is composed mainly of two methods or two categories, which is unsupervised and supervised learning. In the supervised learning, there is a definite input and a definite output, but there is a human supervisor. So the human being is interfering in this type of learning, while the unsupervised learning, the programs aim to identify constant pattern without human supervision. The robots in our work in the future is part of artificial intelligence. However, they are entirely different, because a robot is considered to be a static condition, because it's performs tasks without further intervention. However, the artificial intelligence try to emulate the brain. A deep network is the machine learning unit. It's an example of how the machine learning is progressing in the form of an input layer and output layer with a hidden layer in between. One of the an example is to try to proceed for a certain decision. We have different networks like the Bayesian network and the support vector machine, in which there is it's a decision model which combine the margins of the known data to reach to a solution. As for to detect or to predict problems with endovascular aortic repair. In aneurysm, in AAA, artificial intelligence have different tasks. First, it's very important in imaging that it could give us many idea about the morphology, geometry, and the fluid dynamics, as well as presence of intraluminal thrombosis and calcification. All this aspect could be achieved, as well as it's important for planning and sizing of endograft. Also, it's very important to score the aorta and the anticipating of rupture and the anticipating and how much this aorta may rupture in the following time. Also, it's considered the post-operative outcomes and surveillance of the aorta or the aneurysm after repair. This is a machine learning unit. We have a patient input with different data, clinical history, surgical data, to reach at the end with the pattern of algorithm to decision making. This is an example for how the artificial intelligence could do for the AAA. Here it could this is type of software which is called Prevaorta or Neura, which is using artificial intelligence to plan for the AAA and to do a surveillance for this aortic repair thereafter. This is another method using the artificial intelligence, and here we could precisely detect the no-go zone, which is a zone not to cover the lowest renal. This could be also achieved through the artificial intelligence. The same also, the machine learning could detect the endoleak. For example, here on the left side, this is the image obtained by CT angiography, and this is the specialized radiologist could detect the endoleak, and here the last table or the last one here is the machine detecting the endoleak. So it's considered to be a step in the future to for the machine to detect the endoleak without human interference. The same also there is a geometric and biochemical modeling in order to anticipate the growth of the aneurysm and anticipating its rupture thereafter. Considering FEVAR, the report has come into or many steps have occurred to use the robots in FEVAR. It's very important that the robots can do a very sophisticated task in the form of active maneuverability of the tape, stabilization of the delivery system. It's also it's very important for branching or cannulation of different branch. However, it's very costly, and the benefits of accuracy, easier branch cannulation, and the avoidance of radiation exposure, all this faced by the much cost and the wider and the lack of wider applicability of the robots. The first robot was used in 2009, and this was for cannulation of the contralateral limb. And this is the workstation outside the room, and in the matter of, or in the matter of master and slave fashion. The master is the human being and slave is the machine. This is the remote catheter manipulator, and the wires with rotation, insertion, and angulation all are mastered from the workstation outside. So what is the take-home message? The artificial intelligence become a cornerstone in patient selection, anticipation of comorbidities, measurement and planning for EVAR, proper stent deployment, and precise follow-up could be also achieved. At the same time, the robots can have a very important steps in manipulation of the different wires and the catheters. Also, it is faced by much cost and the application of wider applicability of this maneuver. So it's a future. We have to be enthusiastic to think outside the box and use the new technology to achieve better and safe achievement in our practice. Thank you.
Thank you, Dr. Amr. Let me invite the beloved Marwan Yusri. He's a professor in Qasr Al Aini Hospital, and he's one of the eminent endovascular surgeons at our unit. He will talk about post-EVAR aneurysm rupture.
Good afternoon, dear professors and colleagues. First, I would like to thank the organizing committee, Dr. Magda Hagag, Dr. Nasr Said, for their kind invitation to this marvelous meeting. My talk today will be about post-EVAR aneurysm rupture. After its introduction in the 1990s, EVAR rapidly supplemented traditional open surgery as the dominant treatment for modality for AAA. Compared with open surgical repair, EVAR is associated with lower morbidity and short-term mortality. However, it's also associated with more graft-related complications. The perioperative mortality of the elective AAA repair in the EVAR is 1.1%, while in the open surgical repair it's about 40.4%. However, the re-intervention rate after elective EVAR is reported to be between 20 to 40% in long-term follow-up. After 15 years of follow-up EVAR1 patients, it was found that the total and the aneurysm-related mortality were lower in patients who received EVAR in the first 6 months. However, after this time, deaths in the EVAR group increased, and after 8 years of follow-up, both total and aneurysm-related mortality were significantly higher in the EVAR group. After the first 6 months, the increased aneurysm-related mortality in the EVAR group were predominantly from the secondary SAC rupture. The incidence of aneurysm rupture following EVAR ranged between 1.3 to 7.2 per 1,000 persons per year. For patients treated with open surgical repair, the incidence is about 0.3 to 0.8%. However, post-EVAR rupture is associated with a mortality rate of 20 to 60% according to different literature. This complication might partially explain the loss of the early survivor benefit of EVAR compared with open surgical repair over time. Ruptured post-EVAR can be divided into early ruptures that occur in the early perioperative period, It represents about 50% of the cases. However, the incidence of early EVAR rupture is decreasing in the recent publication. The most common cause of early EVAR rupture is aneurysm that was not completely excluded after deployment of the device, either due to type 1 endo leak or the limb mal-deployment. The early rupture usually have a fatal course in more than 50% of the cases. However, late rupture, the most common time for late rupture is about 2 to 3 years after the initial EVAR. Patient with an initial AAA diameter more than 65 millimeter had a shorter time interval between the EVAR and the rupture following it. The most common symptom of ruptured EVAR is like the ordinary rupture is abdominal pain, back pain, hypovolemia, collapse, or syncope. But interestingly, a small percent of patients may have rupture diagnosed while they are doing their routine surveillance, like asymptomatic patients. Endo leak is by far the most common cause of rupture following EVAR, followed by graft migration, other less important causes like inflammation, infection, or rupture of the ileal components. Can we see here the distribution of the type of endo leak? With the most common type of endo leak is type 1 and type 3. Small group of patients has unspecified type of endo leak. The diagnosis of endo leak occurred either with CT findings or during intraoperative. The table shows the characteristics of complication of EVAR, including endo leak. For example, we can see here type 1 is central located and close to the attachment site of the endograft, while type 2 is peripherally located and close to the origin of the involved vessel. This is an example for type 1A endo leak. This is a type 1B endo leak, with endo leak related to the distal attachment site. This is a type 2A endo leak related to a patent lumbar artery. Here we can see a type 3A endo leak due to disconnection of the two limbs. And we can see here type 3B due to graft material defect. Despite coordinated follow-up, many patients with delayed rupture presented with new issue related to their repair, which lead to rupture. This would suggest that more rigorous surveillance of at-risk patient is warranted. But the problem is at-risk patient need to be identified. Several studies the characteristic of patient with ruptured EVAR in order to define the risk factors. Thomas et al. In 2019 reviewed 4,870 EVAR patients in the Vascular Quality Initiative between 2003 and 2017 and documented that both sac expansion and the stable sac were associated with development of new endo leak. Sac expansion was defined as increase the risk is the diameter of sac more than 5 millimeter, while sac regression defined as decrease in the diameter more than 5 millimeter. The aneurysm sac behavior is associated with the development of new endo leak interventions and long-term mortality. Not only the sac expansion, but any failure of the sac to regress is associated with higher long-term mortality. Sac regression patient experience 5 and 10 year survival rate better than sac stable patient. Also, ruptured aneurysm as the index indication for repair were significantly associated with increased risk of post-EVAR rupture. The ruptured aneurysm as indication for the index procedure doubled the risk of post-EVAR rupture, and also shortened the time between the initial EVAR and the rupture following it. In a 10-year multi-century registry, Candle et al. Demonstrated that age between 80 and 89 years at the initial EVAR and urgent initial repair was independently associated with delayed rupture, and the mean age of rupture for patient was 77 years. EVAR outside FU, although many reports suggested that EVAR may be safely applied outside FU, large studies with long-term follow-up suggested that the durability is compromised over time with an increased incidence of type 1A sac expansion and the need for early intervention. In post-EVAR rupture, the IFU was adhered to in only 44% of cases, markedly lower than the 79% in the overall EVAR cohort. This outcome suggests that the operator may need to exercise caution with performing EVAR outside FU. Several studies also have shown that the patient with large aneurysm at the greater risk of significant complication after endovascular, including the EVAR1 and the Eurostar. Also, Zarin et al., the studying patient with aneurysm stent graft showed that large preoperative diameter of the aneurysm, more than 6 centimeters, was the only independent predictor of aneurysm-specific endpoint of rupture. The result of ENGAGE registry showed that the patient with neck diameter more than 30 millimeter has 3-fold greater risk of developing endoleak and 5-fold risk of rupture. This might be due to less overlap in the neck. One moment, please. Compliance with lifelong follow-up is poor. For example, among Medicare beneficiaries in the USA, only 50% was committed to follow-up, but 5-year. Patient in the EVAR1 trial also about 50% committed at 6 years. So a dynamic prognostic model has the potential to tailor surveillance and identify large population of patients who may require less intensive follow-up. A different type of score was formulated in order to identify patient at risk. I will mention 2 of them. The St. George Vascular Institute risk was developed in 2 UK centers and divide the patient to high and low risk. In conclusion, the Achilles heel of EVAR remains the durability of aneurysm sac exclusion. Most of patients with delayed rupture showed aneurysm size expansion with concomitant undetectable endoleak. Strict surveillance and follow-up are required, especially in patients with risk factor to reduce the rate of rupture. Thank you.
Thank you, Professor Marwan. Next speaker again, Professor Magdi Hagag, talking about bridging stent in FIVAR and BIVAR in aortic graft future.
ده بس ايمن استنادوني اعتذر فكان لازم احضر حاجه ودي تكمله يمكن للتوك الاولاني اللي انا قلته. في missing data about bridging stent. FIVAR و BIVAR we do it a lot. We face some problems, but overall we can do it smoothly. But the problem, the bridging stent we put is out IFU. There is no instruction of use of these covered stent graft or bridging stent to be used in fenestrated or branched graft. I mean, they are not tested for this purpose. So there is high re-intervention rate often related to the bridging stent. The concern exists about the durability, as there is no guidelines regarding the ideal technique for joining the fenestration or the branch with the ostium of the visceral vessels, and no devices appear on the market before they have been tested. Being outside IFU, or there is no instruction of use for bridging stent, so there must be a caution about the patient consent, as you will operate on the patient by a device which is not tested. So you tell that complications are liable to occur at any time from this part of the procedure. As I said, none of them is labeled for this use. The re-intervention rate after 2 to 3 years is 33%, and after 5 years is 50%. Re-intervention in FIVAR and BIVAR almost only because of bridging stent. Either they are occluded or they are stenosed, or there is associated endoleak, and you cannot define or diagnose the problem in the bridging stent because they cannot easily be diagnosed by conventional CT angiography, and you have to do angiography, conventional arterial angiography, and even though you might not get the reason. Concerning this, the structural failure of this bridging stent, either fabric disruption or stent fracture with leak or complete separation of the stent. When we choose the bridging stent, we depend upon the device availability. As they said, a bird in the hand is better than two on the tree. The cost, the sheath size, and the result before about observations of using a bridging stent of a special type in different centers. We have to have an idea about the different bridging stents used in the market. The Advanta balloon expandable stent with dual layer of BTFE and stainless steel stent. For my experience, Advanta is a very bad bridging stent. And if you want to know the reason, I will tell you after the B graft or the Bentley graft, inner cobalt chromium stent with an inner BTFE membrane. This means that it's a single layer membrane. And that's why when they show the single layer membrane is liable to complication, they doubled the layer and they made it 4 layers from outside in the, as you see, and call it B graft plus. The Eventus is cobalt chromium also like B graft. Viaban, self-expanding nitinol stent, this is the old Viaban. The new Viaban is Viaban VBX stent, a stainless steel balloon expandable stent structure fully surrounded by, double layer of BTFE. And the inner layer of the membrane is coated by Carmida bioactive heparin surface. وكلكم عارفين الهيبرين كوتد جرافت بالكارميدا عشان يبقى covalent ما هواش ionic attachment of the heparin. 3 issues for the bridging stent: the delivery and the morphology and the durability. Actually, what's important is you use these stents either from brachial axis or from the femoral axis. And so you choose the graft with good trackability and good alignment and good visibility to reach the target vessel. So you need accuracy, flexibility, visibility, and simple balloon expandable stent, and it's better to be used with 6 French axis. The ideal stent we prefer, the stent which is, where the proximal robust section against the separation at the beginning يبقى قوي في أول حتة فيه. كان بفلير في ستنت الفليرنج بتاعها يعلى 2 بس ما يعلاش 4. Strong at the junction of fenestration. والtarget landing zone in the visceral branch can resist kinking and has some flexibility to adapt the visceral branch. دي أمثلة من ال bridging stent problems. أول واحدة دي complete separation and of the covered stent. الثانية membrane rupture. زي ما انتم شايفين على اليمين كل الستنت موجود بس في كورة من الليك حواليها، ده يعني الكفر بتاع البي تي اف اي هو اللي فرق. المشكلة في الحالات دي انه مش كونها تحصل وبس، في high risk of endoleak type 3 او complete disruption of the stent graft أو discontinuation of the arterial supply للtarget organ، يعني اتقفل renal artery طارت kidney، أو risk of long of losing respective organ أو الانيوريزم ساك enlargement and rupture. والري انترفنشن نفسه ما هواش السهل اللي لازم هتطلع منه من غير موربيديتي ومورتاليتي عاليه، واحيانا وانت شغال في الري انترفنشن ما تقدرش تكمل لانك ما تعرفش تجيب الديستال بارت اللي هو سيبريتد من البريدجنج ستنت. المشكله ان احنا مش عارفين نوصل لحل في البريدجنج ستنت، لانه زي ما قلنا هو لو اي اف ملوش كرايتيريا اوف ليبل، فاللي بيريبورت ما يجيبش على نفسه ريبورت على حاجه ما هياش ليجل انه يستعملها، فكله بيتكلم يعني مع بعض كده من غير بابليكيشن تتنشر. البريدجنج ستنت قلنا اوف ليبل، وبعدين المشكله في الدايجنوزس. دقيقه واحده بس. الحاجه المهمه الثانيه مش على الدايجنوزس بس، انه في مشاكل وانا بحط البريدجنج ستنت. انا بشتغل كده، يمكن في مصر ما عندناش الفيوجن ايمج ولا الاونلاي، لكن بننتهي في الاخر بنحط البريدجنج ستنت في الفنستريشن او في البرانش. لكن في نقط مهمه لازم تتعرف، انه الستيف واير والديفايس اول ما يدخلوا الاورطه بيغير لك مكان الاورفيسيز بتاع الفيسلز، وهثبت لك ده دلوقتي ازاي. فمعناها انه حتى لو ما فيش فيوجن ايمج، التخيل بتاعك في الدايجنوستيك سي تي اللي عملت عليه بلاننج ما هواش هو ده اللي على العيان. هنشوف الكون الكونتراست انهانسد كون بيم سي تي لما نقارنه بالكونفنشنال سي تي العادي. بصوا الديسبيسمنت قد ايه، يعني اللي فوق ده الكونتراست انهانسد واللي تحت الكونفنشنال سي تي العادي. ممكن يحصل الشفت ده لدرجه ل1.8 مللي لحد 7 مللي. متخيل لحد 7 مللي يعني ايه؟ يعني ممكن الرينال اوستيوم اللي انت حاسبها في البلان 7 مللي تكون كلها شفتد في حته ثانيه، فده يجيب مشاكل في اللونج تيرم بيتنسي بتاع بريدجنج ستنت. اللي عايز اقوله في الاخر انه ما زال الفيوتشر موجود، لانه up till now there is no ideal stent labeled with instruction of use tested by technology for use to be used in fenestrated or branched graft. Thank you.
Thank you very much. Do we have time for questions? 5 minutes. Can I ask the first question? No, for Professor Marwan. Professor no, just you did present a very nice topic actually about rupture stent. So do you have some evidence from your own experience in the subgroup of rupture stent in rupture patients compared with the elective patients, and in elective patient subgroup about patient treated with aortoiliac and fem compared with the people treated with bifurcated graft? Do you have any evidence or any data to provide us with? Even
I think in our experience, the number of patients dealt with rupture post-EVAR is quite low. But we haven't seen any difference between a patient having EVAR for the initial phase for elective or ruptured.
Yeah, but I agree actually about the low risk of mortality in rupture stent, because we did our study actually over something like 300 patients, and we found actually stented aorta actually carry less mortality if treated with another cover stent.
Yes. So, this is evidence. Yes.
Just I want to ask you, in your presentation, you said that shrinkage of the diameter of the abdominal aorta is a sign of good success. If, for example, I have diameter 6, so for example, 6 centimeter, and it remains for 2 years stable, is this successful also, EVAR? Yes. Shrinkage is mandatory.
Yes,
To say it is
successful
successful.
EVAR is successful exclusion of the aneurysmal sac. We are talking here about the high-risk patients. They are more liable to rupture. Recent study found that even the sac that remain steady, that not it not expand, have a shorter life expectancy, more evidence of more rates of reintervention, and more rates of ruptures. So to say that the patient is low risk, the sac should be shrinkage at least 5 millimeters per
So
year.
if remains the same size over 2 years, because we have
This is high risk patient. This is high risk patient.
High
And they
risk
have
patient, yeah.
high incidence of EVAR rupture than the patient who has sac that regress. And it should regress more than 5 millimeters. Even if the regression is 2 or 3 millimeters, this is considered a stable sac.
Okay. My second question, by your experience or by your study also, do you think that type 2 endoleak can cause expansion, significant expansion of the aneurysm sac after EVAR and can lead to rupture? Type 2, I mean type 2.
Yes, yes, of course. The guidelines say that the type 2 endoleak that was not associated with sac expansion can be monitored for at least for 6 months. But there is a growing evidence and a growing case reports that reporting rupture of the sac from patent type 2 endoleak.
Okay, thank you very much.
Thank you.
It's another comment. It's very good to think in the future, but the question is that do we need to live in the future, especially if you don't have the tools? My word is about the whole studies done about EVAR, treated, and every kind of progression in this field. Yes, it reminds me like the book of Vascular War. It's a war initiated by the companies with their alliance of the IRs, interventional radiologists, to make the way paved to kick off the vascular surgeons out of the battlefield. This is my impression about. I have a perioperative mortality of 1.1% for the EVAR versus 4% for the vascular surgery or the open repair, and a re-intervention rate of up to 40%, and a loss of follow-up of 50%. And we are initiating problems and trying to find more technology to solve these problems. So what this means to us? It means taking all of the resources in favor of two persons, the IRs and the companies, and taking the field of the vascular surgeons in their favor. So are we in the right track now? In our low economy standards, and in this way, with a disease representing less than 1%, are we tackling the proper track? This is a common question. I understand Dr. Magdi will respond.
Fraction of second. Take fraction of second. What worried me actually, I was telling Professor Hagag that we start to see over the last 35 years now our work of the EVAR, the complicated EVAR now. So knowing Egypt and knowing the service in Egypt, because that's my country, okay, we don't have a proper database and proper medical record notes. So where the patient will go if he had a complications, and who going to treat him if the principal surgeon not anymore in the same catchment area. So I need a record.
الريبورت ما بقاش مع البيشنت، لا مع الدكتور مسعد. بس انا حبيت اقول ان الباتل دي موجوده من الاول، لكن في الانوفيشن بتبقى ويفز. اللي ابتدى الويف الاولانيه كان بارودي، زي ما قلت لكم هو عمل الجرافت وما كانش متوقع نهائي ان هيبقى فيه اندوليك وهيبقى فيه رابشر وهيبقى فيه كل المشاكل اللي احنا بنشوفها اللي جت بعد كده. فهو البداية كانت لازم حد يولع الشرارة الأولانية وبعدين الناس تجري. فأنا القصد من السيشن دي، هل الويفز دي خلصت ولا احنا لسه فيها؟ لا، احنا لسه فيها، بنكمل الفيوتشر بتاع الفكرة القديمة.
Mr. Chairman, for this disciplined session, I just would like to announce we'll start the opening ceremony now. We still have 3 sessions, so I beg your pardon to start our At the beginning, I just would like to welcome and say hello for you again. Actually, I appreciate your effort to come and share us. I know you may spend a long time to come here. And also, I would like to thank our guest speaker coming from some Arab country and Europe and America will share us. Now, to cut the long story short, because we are in a shortage of time, I just would like to introduce the EVC board. So Dr. Assam Al-Qadi is my close friend. Actually, we spent more than, no, can you come please here to say hello for them? More than 35 years, he used to be my boss and he upgraded and lastly, I got rid of him, and I think he will never come back again as a head of the department, hopefully. So you can say hello.
Oh, hello. It is a great pleasure and honor for me to be here in this great conference. Actually, I welcome you all again, and I hope for you to enjoy this scientific and a bit of social event in this lovely and beautiful part of our country.
Thank you, Dr. Assam. For your knowledge, Dr. Assam will be the president of the next year, EVC conference next year. My second friend, I would like to introduce him for you. He is my frenemy. I don't know, you know what I mean with frenemy. Frenemy means friend plus enemy. Who would like to be my frenemy? Dr. Mustafa Suleiman. He's around. He's not around. Please, no one tell him what I did say now. So, Dr. Omar Farouk, he's our fruitful guy. He is the apple of my left eye.
Bismillah ar-Rahman ar-Rahim. Thank you very much for the kind invitation. Professor Nasser Saeed have done really quite a lot of effort in the last 3 months to get us here in spite of these circumstances. And I welcome our dear guest from abroad. I hope we all get out of a lot of benefit from this Congress. As in our Quran, we have been told to increase from knowledge. وَقُلْ رَبِّ زِدْنِي عِلْمًا. And thank you very much.
Thank you, Dr. Muhammad. Dr. Ayman Fakhri is the last friend in the EVC board. He's a Venus man. He's a king of the Venus problem in Egypt, solving. Okay.
Thank you, Dr. Nasser. Bismillah ar-Rahman ar-Rahim. I'd like to welcome you all. And I don't want to repeat any words. We are here to celebrate the year, and we promise you the best for the upcoming days, the best for sessions, best for knowledge, and best for the hospitality. Please enjoy our program. Thank you all, and we'll meet peaceful sessions. Thank you.
Thank you, Professor Ayman. I just remembered now, Albert Einstein said one day, what do you say? When you look at things, when you change the way you look at things, the things you look at change. Are you got it? When you change the way look at things, the things you look at change. Why I'm saying that? Actually, I'm saying because this conference this year may be quite a bit different than before. Our aim or main target, we would like to introduce something new, and I think artificial intelligence is our target. Artificial intelligence changing our life dramatically, very quickly, and I think if we can catch and proceed forward and join the innovation, I think this may be something's no good. The most important things I would like to remember our dear Dr. Tariq Radwan. He passed away a couple of years ago, so my sincere condolences to his family. May Allah rest his soul in peace in paradise. Let me give you some remark about this conference. Actually, we have 24 sessions with more than 120 speakers from our lovely country, from Arab country, and from Europe and America. So we don't like to, I feel sorry because we may not have enough time for entertainment. So if we can stick to the time and go forward as scheduled, we may have some times for entertainment. And the good news, we have some cancellations, but not many. So I don't like to spend long time in celebration and ceremony. So we'll cut the long story and continue, go back to our session. Thank you very much. Let us start, hit the mark, and full steam ahead. So may I ask the chairperson and the moderator for the next session, Dr. Ayman Abdel Fattah, and the speaker should be ready. I beg your pardon because we will just play a video, just a video, 2 minutes. This is important. I'm sorry because I forget.
So VC and EVC برحب بحضراتكم جميعا معانا في الأقصر، أحلى معبد مفتوح على وجه الأرض كلها. أتمنى لكم إقامة سعيدة. أنا سعيد جدا بتشريف كل أساتذتي القدام، كل رؤساء الجمعية السابقين.
تاريخ طويل للEVC. المؤتمر السنة دي هيكون مختلف عن كل سنة بالفعل وليس بالكلام، بيتناول كل المواضيع الجديدة، وأهم موضوع أحب أن أنا أأكد عليه هو الارتفيشال انتليجنس. كلنا عارفين الارتفيشال انتليجنس دلوقتي بقت تغير حياتنا اليومية، وبالتالي هتغير طريقة تعاملنا مع الفاسكولار ديزيز والتدخلات تحت الأشعة. طبعا دي نقطة مهمة. احنا كنا مركزين في many distinguished speakers سواء من مصر أو الدول العربية أو يوروب أند أمريكا هيتكلموا في هذه المواضيع، هيغطوا كل المواضيع. أنا حريص إن أنا أؤكد على حضوركم للاستفادة، لأن إن شاء الله دي أعتقد هتغير من طريقة تفكيرنا وتعاملنا مع الأمراض اللي إحنا متعودين عليها. إن شاء الله السنة دي يكون ناجح بيكم طبعا بالمشاركة الفعالة.
Thank you very much, Professor Dr. Nasser Said, for this kind invitation and this lovely conference. Let me welcome first our chairpersons, Dr. Omar Mohammed Al Farouk, Dr. Omar Tanili, and Professor Dr. Ayman Abdel Fattah. Let me introduce Professor Dr. Ayman Abdel Fattah, our head of the department in Shams University, the Vascular Surgery Department, and he will talk to us today about the artificial intelligence applications in AAA.
Assalamu alaikum. Good afternoon, ladies and gentlemen. First, I would like to thank Dr. Nasser Said and the EVC board for their kind invitation. I'll speak about artificial intelligence in prediction of AAA risk. Artificial intelligence corresponds to a broad discipline that aims to understand and design systems that display properties of human intelligence, such as reasoning, learning, adaptation, interaction, or sensory understanding, include analyzing large amounts of data, recognizing patterns, and predicting outcomes. Although research and development of artificial intelligence in healthcare is being conducted in many medical subspecialties, only a few applications have been implemented in clinical practice. Artificial intelligence applications are being evaluated in the realms of vascular diagnostics, perioperative medicine, risk stratification, and outcome prediction. Artificial intelligence applications in medicine and vascular surgery should be designed and implemented with the aim to assist, but not replace the healthcare provider. The goal is to use information efficiently beyond the processing capabilities of humans, thereby decreasing clinician cognitive load, expanding patient-centered treatment options, and improving patients' outcomes. Can artificial intelligence help in AAA? The decision to treat AAA relies on the evaluation of the balance between surgical risk and the risk of AAA growth and rupture. Even though large initial maximal diameter is a well-established independent risk factor for AAA rupture, other factors for rupture, including general characteristics of patients such as female sex, hypertension, or smoking, and factors related to the aneurysm itself, including AAA growth rate, wall stress, wall stiffness, wall tension, and the rapid increase of intraluminal thrombus have been identified. Prediction of AAA growth and rupture. The software allows the segmentation of 3D model of the AAA based on CTA images in a semi-automated manner, where the software identifies lumen, intraluminal thrombus, and the outer contour of the vessel wall, while the investigators make manual correction. Adding patient data to the program with calculation of other parameters as peak wall stress, peak wall rupture index can improve AAA prognosis prediction, either to reach surgery threshold or rupture risk. Geometric and biochemical modeling aided by machine learning improves the prediction of growth and rupture of small abdominal aortic aneurysm. Mortis et al. 3D printing AAA models to aid learning and intervention. This is a recent paper by Boyle et al. This launched just February 2020. The accuracy and reliability of the 3D printed aortic templates, comprehensive 3-dimensional analysis. They concluded that the printed models of 3D aortic templates are accurate and reliable, thus can be widely used in endovascular surgery and interventional radiology departments as aortic templates to guide the physician-modified fenestrated stent graft fabrication. Also, these 3D models can be used for patient demonstration and education. However, others, Juliet et al., They studied the artificial intelligence in abdominal aortic aneurysm, and they reported, although a large number of models have been developed, their performances are not optimal and not always adapted for each patient, as the prognosis may differ widely according to the procedure, open or endovascular, and its context, whether elective, emergency, ruptured, or non-ruptured AAA. Actually, this is different studies used the predictive value for AAA evolution or post-operative outcome. As regarding the growth, there is two studies. One study 94 patients for 1 year, and other 79 patients for AAA, followed up to 2 years. The benchmark learning techniques using non-linear kernel support vector progression with two features and hyperparameter optimization using the nested 5-fold cross validation. They found that they can predict the average AAA growth of 3.4% at 12 months and 2.8% annually for the 2 years study. As regarding predictive value of rupture, there was three clinical cases, calculation of time-dependent specific parameter based on 8 biochemical parameters, and they found that a specific parameter value classified the patient's status correctly in all cases. Another use of artificial intelligence is the prediction of post-operative outcomes, which may be in hospital mortality or reintervention. In hospital mortality, they used 4 variables with ANN comparison with multiple logistic regression and Glasgow aneurysm scale score. Also, they found there is a significance in prediction of the hospital mortality using the artificial intelligence. Reintervention after EVAR, also there is 3 studies. Although they are studied the different parameters of artificial intelligence, they found that also they can predict the reintervention rate for EVAR using different parameters and the different reports of different studies. In conclusion, Mr. Chairman, artificial intelligence has many evolving applications in AAA at all aspects, either diagnosis, management, training, or prediction of outcomes. Thank you.
Thank you very much, Professor Dr. Amin Al-Fattah. And unfortunately, we are missing the next 3 speakers, but let me introduce the last 2 speakers. They are 2 eminent rising stars in our vascular surgery department in Ain Shams University. The first one is Dr. Abdurrahman Magdi, and he's talking to us about, is it time for dynamic interventions?
Bismillah ar-Rahman ar-Rahim. This is Abdurrahman Magdi, a lecturer of vascular surgery at Ain Shams University. It is a great pleasure to be a part of this wonderful conference. And my topic today is a question. Is it time for dynamic interventions? Is it time for dynamic interventions? And I think this question is actually from the future. And as any question, in order to answer this question, we have to understand the question and the concept behind it. Unfortunately, most of us deal with the vascular system as a static system, but actually it is the most dynamic system in our body. So let me introduce some dynamic aspects that can affect our vascular system. A beating heart, your beating heart, as long as we have a beating heart, there is not only a change in the systolic and diastolic pressure through the cardiac cycle, but also a configurational change to the large vessels attached to the heart, as we are going to see. What about the aging? As we grow old, our vessels also grow old. So how this will affect our intervention? Movements, we all the time do our interventions to a static patient on the table, but this patient will move later on. Pressure, despite being a major part and a fundamental part in the flow equation, it is usually underestimated either in diagnosis or even intervention. So what about the beating heart? Let me introduce to you this paper talking about the dynamic morphology of the ascending aorta and its implications for proximal landing in thoracic endovascular aortic repair. And this is a major change now in the direction of management of AAA or the arch pathologies to land in the ascending aorta. So what this paper says is actually that the entire ascending aorta showed a variable dynamic anatomy during the cardiac cycle. Precise ascending aorta sizing using the average aortic diameter and systolic CT angio series may be considered. The mid-ascending and distal ascending segment showed a favorable forms for TVAR using a regular cylindrical endograft design. But unfortunately, for the proximal part of the ascending aorta, showed a pronounced conical form. Therefore, a specific endograft design should be considered to the proximal ascending aorta. Another beating heart, and we have to take care about this specific situation, talking this, when we look at this paper, talking about optimal sizing for aortic stent graft for blunt thoracic aortic injury. Considering the hypotension and related decrease in the aortic diameter, let me introduce to you this shocking info. In a hypophthalmic state or during a hemodynamic stability, aorta size may decrease by approximately 30%. The sizing you do to the patient in the ER is not the actual size of the aorta. You have to do the sizing intraoperatively after resuscitation of the patient or preoperatively after resuscitation of the patient. The actual size of the aorta, and due to the high elasticity, is not the actual size of the stent graft you should put. There will be a very high risk of migration if you use the sizes used in or assessed in a hypotensive or hemodynamically unstable patient. Aging. As we grow old, the elastic component of the blood vessel is decreased. Let me show you this interesting figure about what is the difference between an elastic fiber when it gets shorter and a non-elastic fiber when it gets shorter. There is a bending in the artery. So do we respect this bending in old age people? I don't think. As people reach more advanced ages, the blood vessel may lengthen beyond the point of slack and be tortuous all the time. This review from the Nature journal, aging modifies the structure of the blood vessel even down to the level of the capillary basement membrane. And these structural alterations can then lead to vascular stiffness, impaired endothelial function, and increase the blood-brain barrier permeability. And a thorough study of the underlying mechanisms and key mediators of these age-related vascular dysfunctions would be beneficial in the search for potential interventions. We need to respect the age. Movements, we do all our interventions in a supine static position. And if you think that old vascular patients will not move so much, please think again. Old people can do funny things when they are excited, and this is their right to move and to dance. So will these movements affect our intervention? Let me show you some examples. This is the example after a carotid intervention by carotid end arthrectomy when the patient head is in the neutral position and when the head is bent. This is the image for the carotid end arthrectomy, as we can see, in this and this in the king position, and this is after carotid artery stenting. Do we respect this movement? I think we respect, but the stent does not respect. What about the aorta and the iliacs? Let me show you this very interesting paper about the in vivo deformation of the human abdominal aorta and common iliac arteries with hip and knee flexion. They studied the MRI figures of the patient in the supine position and in the fetal position or in the squatting position. Let me show you how the difference in length of the aorta. For the aorta, there is shortening of the aorta from 92 millimeter to an 89.3 millimeter. So these are 2 millimeters. In the iliacs, from 44.8 to, in the fetal position, 42.6. So we are talking in the sum of these two numbers about half a centimeter. Not only this, what happens also is the right common iliac, the left common iliac, and the right common iliac vessels are translated superiorly for the left by 6.8 millimeter and for the right by 8.7 millimeter. These observed deformities probably result from the interaction between the musculoskeletal and the vascular systems in the lower extremity. These deformities may actually predispose to endografts migration, resulting in type 1 or type 3 failures. The inability of an endograft to lengthen, shorten, or bend according to the change in vessel length or curvature may impair fixation at the proximal and distal anchoring sites. Again, we respect this, but the stents do not respect it. This is an interesting figure also about the bending point in the iliacs. So every time we think the bending point is at the head of the femur. No, this figure shows the bending point of the iliofemoral segment is actually above the head of the femur, as we can see here. So this is the illustration in the an anteroposterior view of the bending point, and this is from the lateral view of the bending point of the artery. And this is the anterior displacement in the MRI. What about the femoropopliteal segment? This very interesting image about a supine and a bent leg. These images show us not only the effect of bending, but also the effect of aging. This is exactly what we said before. This is the bent leg of a young 31-year-old patient. 2 more minutes, please.
1 minute, please.
I think I will need to. And this is the how a bent leg vessels showed in a 52-year-old patient. So it makes a difference. What about the pressure? As we said, despite being a fundamental part in the equation of flow, we do not respect this, or we underestimate the effect of pressure. Despite the main pathophysiology in venous disorders being ambulatory venous hypertension, but unfortunately, all diagnostics till now and the interventions till now, either for superficial or deep venous systems, are done in supine position. So what do we need from artificial intelligence? Through artificial intelligence, future efforts should be directed toward an individually based interventions that respect all dynamic aspects. And to conclude, we need to think dynamic to treat the vascular system, which is the most dynamic system in our body. Thank you.
Next speaker will be Dr. Muhammad Haggag. He's our lecturer in Ain Shams University Vascular Surgery Department. He will speak about SVB classifier application for pelvic congestion syndrome or pelvic venous congestion.
Thank
Okay,
you.
the floor is open.
Thank you, Mr. Chairman. Today we're going to talk about SFB classifier tool. By the end of this presentation, we should know what's meant by patients who have pelvic symptoms, what's meant by S2 or S3A, 3B, V2, V3A, 3B, what's meant by pathophysiology of both gonadal veins showing reflux non-thrombotic with left with the internal iliac vein showing reflux non-thrombotic lesion. At first, everyone knows that chronic pelvic pain is like a pelvic migraine that affect women in childbearing period. According to Milka Griner, she classifies into 3 types: type 1, type 2, and type 3. Type 1 reflux valvular pathology. Type 2 obstructive pathology. Type 3 is a pelvic congestion due to local gynecological cause. This application, this classification have a lot of drawbacks. That's raised the question and the value of the SVB classifier tool. Everyone knows that traditional therapy includes both medical and rarely done surgical. And now the pelvic vein embolization or stenting becoming the upper hand. We should answer by the next few slides why some venous pathology causes different symptoms in cohort patients and why same symptoms in cohort group were of different venous pathologies. Professor Mark Meisner had respond to this question by classifying this into 4 venous systems, 3 zones, 3 reservoirs, and 6 pelvic leak points. Here are the 4 zones of the territory of the pelvic venous disorders. Zone 1 that include both renal veins. Zone 2 that include both gonadals and iliac veins. Zone 3 that includes pelvic and extrapelvic veins, including the pelvic leak points. And zone 4, which includes lower limb veins. And here is the main diagram that show what's meant by uncompressed and compensated or decompressed, and what's meant by when the patient turned from S2 to S1. The left one shows that if the patient, any female who have a pelvic venous disorders have a 3 venous reservoir. The first one is the renal reservoir, the second is the pelvic, and the third is leg reservoir. If some patients have Milka type 1, this means that the pressure in the left ovarian vein and internal iliac veins will transmit directly to the pelvic veins. And this patient have an uncompensated compressed symptoms into the pelvis. If she developed a lower limb or pelvic derived lower limb varicosities, she turns into the right one, which we call compensated decompressed pelvic symptoms. This slide show if some patients have a nutcracker and the main renal reservoir is the primary reservoir. If she developed a secondary gonadal vein reflux due to obstruction, she will transmit from uncompensated to compensated left renal vein. And this patient, if you treat it with left gonadal vein embolization, she will be turned into decompressed pelvic state, and the pain will be aggravated and will be focused on its renal reservoir, and she will turn from S2 or S3 into S1. Here is a symptom varices pathophysiology, and here is a revised SEEP. And this is the main purpose of our presentation today. This classifier tool, everyone can download from his mobile app. It's developed by Professor Mark Meisner from American Vein and Lymphatic Society. It will be simple, you just go through it. If the patient have no pelvic symptoms, you will skip. If they have symptoms, which symptoms, renal or pelvic or extrapelvic, and if it's extrapelvic, you will follow. Then you will turn to the site of varices, pelvic or extrapelvic varices, then to the pathophysiology, which is sub-categorized into 3 groups. Which vein is being incriminated in the etiology, left or right or bilateral, obstructive or refluxing, and this is thrombotic or non-thrombotic or congenital pathology. Then you will turn to lastly to the demographic data of the patient. By the end, you will develop a venous standard reporting that you should report your patient to follow up here, which was the main drawback of this tool. So you can modify to follow up your patient. So for example, this patient, she have a pelvic and extrapelvic and lower limb symptoms. The varices were including in pelvis and extrapelvic, and she have a lower limb varices. The main target vein is bilateral gonadal vein showing reflux. Don't forget visual and log scale and pain assessment is an essential part during assessment of these patients. You should apply SEEP, and don't forget if you did a patient like this one who have her symptoms was S2 that become S1, you should think of obstructive pathology and you have treated not in a correct way. Here is the latest ESVS guidelines 2022 regarding pelvic venous disorder. For patients with varicose veins of pelvic origin without pelvic symptoms, pelvic vein embolization as initial treatment should not be performed. For patients with varicose veins of pelvic origin with pelvic symptoms requiring treatment, pelvic vein embolization should be considered to reduce symptoms. For patients with suspected suprainguinal venous obstruction, in addition to full leg duplex, ultrasound of abdominal and pelvic veins should be considered as a part of initial assessment. For female patients with pelvic pain and clinical suspicious of pelvic venous disorder, exclusion of other causes of pain is recommended. For female patients with suspected pelvic venous disorder, abdominal and transvaginal ultrasound should be considered to confirm the presence of venous pathology. For patients presenting with symptomatic varicose veins, where they may be of pelvic origin, specific duplex ultrasound assessment of pelvic leak points is recommended. For patients with varicose veins of pelvic origin without pelvic symptoms requiring treatment, local procedure for varicose veins and related pelvic escape points should be considered as an initial therapeutic approach. Here are some illustrative cases of pelvic venous embolization before and after. In this case, we use an NBCA. Here is the left gonadal vein being before and after liquid embolization. Here is some picture of right gonadal veins before and after. And here is some obturator and some vulvar escape points. Here is obturator and what's meant by sciatic varices. Thank you.
Thanks, Dr. Hagag, for your nice presentation. Now we'll open the floor for discussion.
As regards to the aortic aneurysm rupture, we still depend on the diameter. Maybe this is the most sensitive issue we have. Do you think artificial intelligence may change our dependence on that, and may we start to concentrate on the surface tension, I mean configuration of the aneurysm rather than the diameter?
No, it will not change, but he will help by adding this stress wall factors in addition to the diameter. As I mentioned, the diameter being the most significant independent factor.
Yes, I agree with you, but I mean the rupture only could happen when the surface tension of the wall become less than the intra-saccular pressure. So if we can get any device or any artificial intelligent way to measure the surface tension of that point, you can say, or you can predict the rupture may happen soon or in the near future. This is my imagination.
They are trying to do that, but nothing, no models after now.
Why I am saying that, actually, I am saying that because sometimes patient coming with aneurysm 5.5 leaking, sometimes coming 9, 10, 11 centimeter. So why?
This is because there is other factors. There is patient-related factors and aneurysm-related factors. Okay, they try to make some parameters, parameters, to add help. Okay, in predicting the risk of rupture and when you have to make intervention. Okay?
Right.
This is try to help. Okay, but no definite factor now available. Okay.
So you're upsetting me a bit, actually, because this is means the artificial intelligence will never change our life as regard to the aortic aneurysm.
No, it's working. The study is
It's
working,
still
and we
working.
have to dream. Okay.
Yes, yes. Okay.
A quick comment, just because this is very important question. There are two things that will tell you if this aneurysm will rupture or not, which is the diameter and the shear force. And now there is a machine learning program using Python in Florida University. The group is shared on Telegram by AI Aorta. Now they are collecting data. They have around 3,000 patients, and they take two parameters. They take parameter and shear force. Now they already develop a program which is 90% accurate. They hope to get it to 97% accuracy. By that time, you will know if you put the patient data into this machine learning program, it will tell you his probability of rupture over the next months is 90%. Then you will put him on the West. It is running. They expect to get 97 by the end of next month. Why I'm saying that? Because the chest radiographer now can diagnose cancer, lung, more than the human eye. So their accuracy is 99%, while experienced radiologist is 97%. So I totally agree this era is coming.
Can I ask you a question? Yes. Okay, that's for Dr. Magdi, Abdurrahman Magdi. Abdurrahman,
Yes.
Abdurrahman, I actually liked your topic, but I don't
thanks.
like your conclusion. Because you said we vascular, we treat muscle. I need to know more about your conclusion. What you mean by treat muscle? If I do a fin bob below knee, by using hybrid system or something, or grafting plus vein, do you allow the patient to sit in certain way, walk in certain way?
No, in the conclusion, I meant about the vascular. We have to respect the vessel in this specific patient.
So you are talking about endovascular, yes?
Both of them.
Or you talk about the grafts as well?
Yeah, for grafts as well. So if this patient is old and his vessels are tortuous.
No, all our patients very young.
When I deal with a young patient with a popliteal entrapment syndrome.
No, seriously, it's very important.
Yeah.
I agree totally with your explanation, your talk, but I don't agree with your conclusion if you cannot explain it well. So if I have to use a special hyper system for below knee reperfusion, I allow the patient to walk in a certain way, yes, and I allow the patient to take special rehabilitation to sit in certain way. Okay, but I mean, same thing for the carotid. Okay, if you put carotid stenting, same thing. Okay, so you should not be shy in your conclusion, but you should not say a muscle, vascular. Yes.
Okay.
I'm sorry.
No, thanks.
There's a question for Dr. Farouk to Dr. Abdurrahman also.
Okay.
Thank you very much, Dr. Abdurrahman, for your lecture, and I hope to see more of your presentation. I have a query about your title. You said dynamic interventions.
Yes.
We know that the diameter of the aorta is not constant in normal patients. That's why we get a gated CT scan, which is ECG gated CT scan. It gives you diameter in systole and diastole. We know that any artery, when we bend, you get a lot of forces. That's why you get flexion angiogram around the knee, and we get flexion angiogram if we put a stent on common femoral artery.
Right.
Everything is changing. Even if the patient is supine, that does not mean it's static. I would go as far as to say there is nothing which is a static intervention, because by definition, intervention is, the intervention cycle. You diagnose, you tackle, you see patient response, and reassess and retackle again. So I wouldn't say there is nothing called dynamic intervention, because all intervention are dynamic. What do you say?
I totally agree with you, Dr. Muhammad, but I just want to raise this concept about there are many dynamic factors that affect, and I think the companies are not aware of these dynamic changes. They are aware only to tackle the diameter, to tackle the durability. The stents are not movable with different dynamic factors that affects our system, like the respiration or the pressure or any other things that we just rose up this idea about the interventions at all.
Thank you, Dr.
Dr. Abdurrahman. For the sake of time, we'll close
Thank you.
this session. Thanks for all honorable chairman. Next session, please. We are inviting them to come here. Thank you.
شوفي حالتك وين كنتي وين صرتي واوسع رجلك كمان اثنيناتهم بموت عم قل لك انا العيب شو عملتي؟ موجود ورا موجود يا باشا تستاهل يعني؟ انت العيب من هون عم قل لك طالع برا انا العيب اوكي انا رايحه
دكتور ناصر نبدا. Now we starting the fifth session. Professor Dr. Ala Sharabi Al-Azhar University. He will talk about obliteration of varicose veins with superheated steam. تفضل دكتور علاء بيه.
Thank you, Mr. Chairman. Thank you for Dr. Nasser Said. I will talk about obliteration of varicose veins with superheated steam. Introduction. At atmospheric pressure, we need more than 2,000 kg to vaporize 1 liter of water, and the temperature of vapor is 100 centigrade. Our target is to obtain superheated steam at 150 centigrade. If pressure several hundred times atmospheric pressure, we will obtain superheated steam 150 centigrade. The superheated steam formed by this machine. This is a picture showing the machine made in France, formed of 1 liter sterile water tank. The sterile water forced under high pressure through very small diameter tube, 0.1 millimeter, heated by an electric current. This tube ended by hand switch control to which a caster can be connected. 5 French single-use caster formed of thin stainless steel tube coated with Teflon. At the tip of the caster, steam is emitted at 120 centigrade through 2 lateral holes controlled by the switch. Picture showing a macroscopic view of heated vein on the left side and non-heated part on the right side. Technique, same protocol steps as other thermal obliteration techniques were done. Before entering the caster in vein, we measure on the skin distance from the junction and apply a sterile tape at the level where we might stop. The steam caster is pushed in the vein through the introducer aboard. The progression easy and smooth. If resistance, guide with duplex to go further. If failure after trials, use guide wire and the 5 French straight and geographic caster. Withdraw the wire and introduce the steam caster in it. It is mandatory to use duplex ultrasound to check that whole length of the caster is in the vein lumen. Checking by duplex the 3 centimeter distance from junction. Ultrasound guided tumescent anesthesia around the vein was done. The first 2 pulses are not pure steam because the caster is cold. The steam emitted by the hand switch condensed before reaching the tip. When beginning heating at the junction, 5 pulses are sent, 2 non-heated and 3 heating pulses. Withdraw the caster centimeter by centimeter. We pulses 2 pulses per centimeter for small veins up to 7 millimeter diameter. We pulses 3 pulses per centimeter for larger veins. We pulses 4 pulses for vein more than 1.2 centimeter in diameter. Between every 10 pulses, stop heating 10 seconds to avoid heat accumulation inside the vein. Care must be taken to avoid the skin burning at the end point during withdrawal of the caster by heating stop at last 2 centimeters, 5 seconds cooling by 5 seconds cooling by ice at site of entry during caster extraction. Last centimeter of caster removed with the cheese. In cases of severe liposclerosis, we can use cooling with a pad of gel to obtain anesthesia during heating. Post-procedure compression stocking for 2 weeks. Walking is assumed immediately. Low molecular weight heparin for 8 days. Post-operative duplex checking next to detect any complications and to confirm that the treated vein is closed. Picture showing disappeared varicose vein after steam ablation. Steam obliteration may have some disadvantage over current technique. It is safe. Grease substance vein can obliterate with only 2 to 3 cc of water. So small quantity will not induce hemolysis. Endoluminal clot is minimal. Inflammatory reactions are rarely observed even in large trunks. Absence of perforation, low risk of injury to surrounding structure because fast heat exchange of water vapor. External cooling may be used when the vein is close to the skin. Heating caster is thin and very flexible. Vein entrance is easier. Tortuosity can be passed easily. Water vapor has several advantages, decreased risk of DVT. Non-chemical is used other than water, so no anaphylaxis. Less inflammation, less pigmentation, faster procedure. Thank you.
Thank you, Professor Dr. Ala Sharaib, for very nice presentation. Dr. Ahmed Musa here. Dr. Ahmed Musa.
Thank you so much for all the EVC board. Now we are moving to the next speaker, Dr. Hani Abdelmomen, Al-Azhar University. He will talk about heparin-induced thrombocytopenia. Dr. Hani. We are moving to Prof. Dr. Muhammad Yahya, Al-Azhar University. He will talk about perforator ablation.
السلام عليكم ورحمة الله وبركاته. بسم الله والحمد لله والصلاة والسلام على رسول الله. Varicose veins, perforating veins, when and how to treat a new approach. By Muhammad Yahya Zakaria, Assistant Professor of Vascular Surgery and Vascular Surgery at Al-Azhar University for boys. Introduction. Varicosity is the penalty for verticality against gravity. In men, owing to this upright posture, blood has to flow from lower limbs to heart against gravity. Varicose veins defined as dilated, tortuous, elongated superficial veins of the lower limbs. The venous system of the lower limbs consists of deep veins or deep system responsible for 85% of the venous drainage, and the superficial system responsible for about 15% of the venous drainage. Between these two systems, there is penetrating veins that communicate directly and indirectly, enabling flow to drain from superficial veins to deep veins. Perforators traverse the deep fascia of the leg while forming communication channels between superficial and deep systems. Perforators, there are many perforator systems in each extremity, which are approximately 150 perforator veins. They are distributed as follows: about 60 perforator veins in the thigh, about 8 in the popliteal fossa, about 55 in the leg, and 28 in the foot. Of these veins, about 30 become incompetent and are defined as clinical plaques. These are the main groups and the subgroups of the perforators in the lower extremity. Clinically relevant perforators. The cuff contains 4 groups of perforators that are clinically most important. The pretibial perforators communicating the great saphenous and posterior tibial veins, the posterior tibial perforators connecting the posterior accessory great saphenous and the posterior tibial veins, the lateral leg perforators and anterior leg perforators. Average diameter obtained from competent and incompetent perforators in the thigh and cuff. There are several studies that reported that the diameter of incompetent perforators is large compared with that of without reflux. Here we found the location in the medial thigh. There is the competent perforators ranging from 2.5 millimeters. When it is incompetent, it will range about 4.7 millimeters. In the medial cuff, it is 2.2 when competent, and when incompetent, it is 3.7. For the posterior cuff and for lateral cuff, about 2.2, 2.1. When it becomes incompetent, it ranges from 3.5 to 3.3. The average diameter of incompetent perforators, when there is varicose vein, I mean seep from 2 to 4. When it is incompetent, it will start from 3.5. For the venous ulcer, I mean seep 5 and 6, it will range from 4.4. The diameter reflux relationship of perforator. The perforator diameter, when the perforator diameter is 2 millimeter, approximately the incidence of reflux will be approximately 10%. And when the perforator diameter is 2.5, the incidence of reflux about 50%. And when it is 3 or 3.5, approximately the incidence of diameter or the incidence of reflux will be 80%. When it is 4 millimeter, it is 88%. For all the incompetent perforator veins, as regarding SEEP classification, from SEEP3, the incompetency about 52%, and the SEEP4, it is about 83%, and SEEP5 and 6, it's about 90%. Types of perforators. We have 2 types of perforators. Direct perforators, they are directly connect superficial veins with the axial deep veins, like tibial veins, anterior tibial, posterior tibial. The indirect perforators connected to the intramuscular veins. They connect superficial veins and the venous sinuses of the gastrocnemius or soleus veins, and often have multiple branches connecting superficial and intramuscular networks. Perforators are often accompanied by arteries and are commonly located in the intramuscular septa. Other types of perforators, mechanism of perforator incompetence, I think we have to buy. We have antegrade pattern and retrograde pattern, but the clinical importance for the antegrade pattern in an incompetent perforator results from antegrade overload. Correction of the superficial reflux alone is often sufficient to normalize perforator hemodynamics and permit return to normal function. For the retrograde pattern in the posterior, in the perforator incompetence develops secondary to uncorrectable deep venous hypertension, eliminating the associated superficial venous reflux doesn't address the underlying cause of the problem, and the perforator cannot recover normal function, and active intervention may be needed. Diagnosis by ultrasound. Society of Vascular Surgery, SBS, guidelines define a pathological perforator vein based on the anatomical location beneath an active or healed ulcer with a reflux lasting more than 500 millimeters or a diameter more than 3.5 millimeters. Treatment. Histological description. In 1917, Homan describes the role of perforator incompetence in the development of chronic venous ulceration and emphasized the importance of surgical disruption of such problem. Almost 2 decades later, Linton first described the medial facial incision and perforator ligation as a mean of managing the perforator incompetence. This technique remains a golden standard for managing perforator incompetence for almost about half a century, despite the associated morbidities, including the ulcer recurrence, wound breakdown, and the neuropathy. However, with the adverse of newer, less invasive treatment modalities, open surgical ligation has been largely abandoned after superficial endoscopic perforator surgery was developed and became widely adopted. We have another tool, superficial endoscopic perforator surgery, SEPS. Also, we have ultrasound-guided sclerotherapy, ultrasound-guided foam sclerotherapy, and lastly, the transluminal occlusion of perforators. The endovenous therapy ablation has been performed for perforators using the radiofrequency or laser. The obvious advantage over conventional surgical techniques and SEPS is the non-requirement for formal anesthesia and the ability to be performed as a day case or outpatient procedure. The RF or laser energy thermally damage the endothelial lining of the venous structure, which will seal the perforator shunt. The perforator will eventually fibrose and remain closed. They reported closure rate of about, can be just a minute. Just a minute.
1 minute, please.
This is endovenous laser ablation technique, and this is the radiofrequency ablation technique. This is the closed surface stylet catheter. Clinically evidence, this is what I'd like to emphasize. Here we have a study, 1 year outcome of radiofrequency ablation in incompetent perforator veins using the radiofrequency stylet device, a cohort study. This is from East Asia. The conclusion, there was no operative mortality in 13 days or 30 days or severe complications in patients undergoing radiofrequency, such as skin necrosis or amputation, or also minor complications including ecchymosis or paresthesia. This is the pictures. Here also a study from the Journal of Vascular Surgery, Venous and Lymphatic Disorders. It concludes that heat ablation after failed foam sclerotherapy resulted in significantly higher closure rate. I will bypass just 1 minute. Here we have many clinical trials that push toward the using of minimally invasive techniques. This is prospective safety and effectiveness study using endovenous laser ablation. This is a study, and the conclusion, endovenous laser study for perforator incompetence using laser yield a safe and effective outcomes with no major adverse sequelae. This is another study. This is the most important one, systemic review and meta-analysis. This is the strongest one, systemic review and meta-analysis of management of incompetent perforator in patients with chronic venous insufficiency. It includes also the current evidence regarding the treatment of incompetent perforators is limited owing to the low adherence of reporting standards. I will bypass treatment of incompetent perforator veins using radiofrequency ablation. Conclusion, radiofrequency may be promising procedure, but patient and incompetent perforator vein selection is important, and further standardization of the procedure is required. Comparative clinical trials may be required. Also, 1 year outcome of radiofrequency ablation. The conclusion, this result demonstrates the radiofrequency stylet device to be effective treatment for endofrequency, minimally invasive. This all
Thank you, Dr. Mohammed Yahya, for this nice presentation. The next speaker, Dr. Hani Abdel Mu'min, he will talk about Behçet disease. تفضل دكتور هاني.
بص اقول لك على حاجه. طيب نقعد نشوف منظر بس، نقعد على ترابيزه. حاسه بيه، حاسه بيه. لا عادي، كان نزلت بس كده بقول لك مصر كده وقسمت.
السلام عليكم ورحمة الله وبركاته. We will talk about Behçet disease. Introduction. Behçet disease is a vasculitis affecting all caliber of the arterial and venous wall. It usually affects young persons, mostly between 15 to 45 years old, and affects both men and women. It is rare after 15 and before 10 years old. Most frequent in patients around the Mediterranean Sea, Middle East, and Southeast of Asia. The diagnosis is essentially clinical. Manifestation include first manifestation is buccal lesion or ulcers present in 89% of the cases. It involves painful single ulcers found around the internal surface of the lips, cheeks, gingival-labial groove, and maybe on the tonsil and the pharynx. Genital ulcers exist in 60 to 65% of the cases, and if present, it is suggestive of Behçet disease. This is ulcer of tongue and ulcer of the lip. Genital ulcers are often deeper and bigger than the buccal one. In men, they are located on the scrotum or rarely on the penis and urethra. In women, they are found on the vulva, vagina, and the trine cervix. This ulcer on shaft of the penis and vagina. Most specific skin test, the pathology skin test, hyperreactivity of the is the basis for pathology skin test. This test is considered positive when babule or pustule is formed on the front of the forearm after injection or breaking. Pathology is the main pathology of Behçet disease, means severe hyperinflammatory response to minor trauma due to increased tumor necrosis factor released from the natural killer cells. This leads to ulceration of the body tissues by minor trauma, such as mouth ulcers resulting from minor trauma from the teeth, and genital ulcers due to minor trauma during intercourse. Other cutaneous manifestations, the form of recurrent erythema nodosum in about 1/3 of the patients, superficial symptophlebitis, acne, folliculitis. Articular manifestation involve maybe early and sometimes it can proceed the other manifestation by several years. This is usually inflammatory oligoarthritis affecting the large supporting joints like knees, ankles. If compared with rheumatoid arthritis, which is multi-arthritis affecting small joints and are destructive. Ophthalmological manifestation is the third manifestation in frequency. Bilateralization of the lesion may be rapid within 2 years. Both anterior and the posterior segment of the eye may be affected. Anterior uveitis is non-granulomatous uveitis. It may be accompanied by hypopyon, which is suggestive of Behçet disease. Anterior uveitis is rarely isolated in 10% of the cases, but it is usually associated with damage of the posterior segment of the eye. When we found young age and male sex with severe initial affection, this means poor prognosis of Behçet disease in visual disease. Macular edema is the most feared complication, which is leads to central blindness, especially if ischemic. The vitreous humor is secondarily affected, may lead to, in the end, may lead to retinal tear and detachment. This is anterior uveitis specific for Behçet disease, and there is clear hypopyon. Fundus examination show macular edema and neuritis of the optic nerve. Fluorescein angiography shows vitreous hemorrhage with neuritis. Another manifestation is neurological manifestation. Damage of the central nervous system may be parenchymatous type. That means the damage of the white matter and the gray matter, and the extra parenchymatous manifestation, which is the vascular, arterial, and the venous affection. Peripheral nerve affection is rare. Neurological manifestation may be approximately in 25 to 30% of the cases. Parenchymatous form affecting 70 to 80% of the patient with neurological damage. Neurological damage appear to be mucocutaneous manifestation, headache more than 50% in association with pyramidal traction affection, cerebral ataxia, sphincter disorders, epileptic manifestation may occur, lymphatic meningitis. Extra parenchymatous manifestation in the form of cerebral thrombophlebitis, which its manifestation include increased intracranial tension, mostly frequent headache and macular edema, fever, focal deficiency, and convulsions can occur. All intracranial veins may be affected. Superior sagittal sinus and transverse sinus are the most affected one. Occlusion of the carotid and vertebral arteries can be found, as well as aneurysm with the risk of hemorrhage and rupture. This is aneurysm of the middle cerebral artery, 8 millimeter and 4 millimeter, the same. MRI angiography shows left transverse sinus thrombosis. Vascular manifestation, venous thrombosis occurs in 30% of the cases. Superficial thrombophlebitis are transitory and migratory, found during the whole course of the disease. Venous thrombosis, they may affect all veins of the body, are often recurrent and sometimes indicative. A typical location such as iliofemoral DVT, IVC, subhepatic cerebral venous thrombosis. VSC must be considered in the presence of unexplained thrombosis in young adults without other vascular factor and with negative thrombophilia. Venous thrombosis may be multiple, associated with arterial involvement in the form of Hughes-Stevens syndrome, associated with DVT, and pulmonary artery aneurysm with risk of rupture. Arterial involvement, they occur in 5 to 10% of the cases. This may involve occlusion of all arterial aneurysm with high risk of rupture, often multiple localized, affects the lower limb more than the upper limb. All arteries of the body may be affected. Aneurysms are saccular, multiple, rapidly thrombosed, easily infected with high risk of rupture. It may occur at any site of arterial puncture, so non-traumatic techniques are preferred. The prognosis of arterial damage is poor since it is the primary cause of death in about 30% of the cases. This is infrarenal saccular aortic aneurysm in male patient. Bilateral popliteal artery aneurysm in this patient, thrombosed on the left and patent on the right. Digestive system, manifestation like Crohn's disease, but not specific. This is intestinal ulcers. Pulmonary involvement, not specific. Fertility. Fertility doesn't appear to be affected during the course of the basic disease by either the disease itself or colchicine treatment. The incidence of mucocutaneous manifestation of basic disease is decreased during pregnancy and postpartum, particularly in female taking colchicine. Thus, taking colchicine appears to be effective in reducing the risk of basic disease outbreak without additional drug danger on the fetus. Diagnosis chart, 4 points or more, indicative and diagnostic. Buccal ulcers, 2 points. Genital ulcer, 2 points. Ocular ulcer, 2 points. And the rest of manifestation, 1 point. 1 minute.
Yes, you can give him
1 minute, please. The objective of treatment in short term provide daily comfort, sometimes ensure functional improvement, screen for potentially serious cases, mid-term prevention of complication, long-term decrease the sequelae and the side effects of the drug used in the treatment. The mucocutaneous lesion treated by colchicine وزيلوكين جل والابريميلاست وانتي-tumor necrosis factors. Articular, the same, colchicine intra-articular injection, ophthalmological, immunosuppressants corticosteroids. In parenchymatous, the same in extra parenchymatous, glucocorticoids, methylprednisolone, cortisone. Extra parenchymatous, the same with anticoagulants. In vascular treatment, immunosuppressive treatment is the cornerstone of treatment of severe BSS disease with vascular complication. It is based on the fact that inflammation of the vascular wall is inflammatory. Another minute.
Thank you, Dr. Hani, for this nice presentation.
The next presenter, may I ask Professor Sameh Al-Imam? Professor Sameh? Professor Sameh will speak about surgical revision of complicated AV fistula in dialyzed patients.
اديته تايم كده على طول. ايه السرقه دي؟ ماشي. Hello everybody, dear Professor Nasser Said and dear colleagues of EVC. Thank you very much for the inviting to the Congress. I know all are tired. I'm trying to finish my talk in about only 6 minutes. We will talk about the surgical revision of complicated arteriovenous fistulae in a dialyzed patient. It's known that the end-stage renal disease is increasing worldwide, and renal replacement therapy and kidney transplantation it simulates burden on the healthcare system. Then, according to the 9th annual report of Egyptian Renal Registry provided by Egyptian Society of Nephrology and Transplantation, the prevalence of end-stage renal disease in Egypt it's around 483 patients per million, and this is a very increasing amount in end-stage renal disease patient in Egypt. The fistula created more distally between the artery and the vein. The surgery is paramount, and this is what we aimed in this study is back to basic surgery, still present, and we have to consider it again. These are the sites of the fistula. According to the guidelines, we start distally to proximally. We have many complications of AV fistulae like aneurysm, like vascular access, arterial syndrome, venous hypertension, thrombosis, stenosis, infections, etc. Physically, you can detect the complications physically by palpable thrill or even by ultrasound. It's called yin-yang sign. This study was done in Al-Zahra University, and it's part of a larger study. We were starting in it just to compare between the endovascular solution and the surgical solutions for the AV fistulae. Till like in 2 years, we were gonna end in final results. So we were aiming at to evaluate the surgical solutions of the complications of AV fistulae. It was conducted on 50 patients in the Zahra University Hospital, and short-term results, 6 months. We have included the native fistulae only. We excluded like synthetic or extra anatomical or hero graft patients. Then we've dealt with the complications according to each complication has been happened to the patient track. The true or pseudo aneurysm we have excluded it. We were trying to preserve the fistula. Stenosis, we were excised the stenosis and we made end-to-end anastomosis. Here a sample of our cases. This is large aneurysm. We have excluded it, and then we have done end-to-end anastomosis. And it's known that in the aneurysm, we have a lot of tortuous veins, which give you a length just to be able to do an end-to-end anastomosis. This is a Steele syndrome. Also, we preserved the fistula. At the same time, we didn't sacrifice the fistula, and we increasing the arterial supply to the hand, so we didn't sacrifice the fistula here. And here we have noticed that the branched veins, it has decreasing the outflow of the veins with the fistula, which decrease the flow rate at the dialysis. Unfortunately, male were more affected than females. Most of us use the technique end to side, not end to end, and we have found that because of most of us has created the fistula at the cubital fossa, we have found that the most of complications are happened at the cubital fossa. Pseudoaneurysm were encountered as the most common complication with 32%. Our success rate was 76%, and I think it's accepted success rate. The patency rate also, it didn't never go down, so that the surgical solution is still best for complicated AV fistulae. To summarize, the pseudoaneurysm were the most common complication of complicated AV fistulae with 32%. Vascular steal syndrome was encountered at the second one. So we have to correct both the fistula and the arterial supply. The rate of infection in our fistulae was around 34%. Thrombosis is common in fistulae, even it's early or late. The post-operative assessment with duplex ultrasound, it enhances the success of AV fistula creation and also outcomes. Also, post-operative assessment is important. The current study is still a small study, and we are going to increase the sample size in the future. Performance of multidisciplinary team, including the nephrologist, radiologist, and vascular surgeons to assess the AV fistula, aiming at decreasing complication rate. Regular surveillance, physical exam, pre and post is very important. And by the way, you are all invited to the AVASC Congress. It will be, inshallah, 15 and 16 June, next June in Grand Hyatt, Cairo. And thank you very much.
Thank you, Professor Sameh, for keeping the time.
May we call upon Dr. Ihab Abdo. He is going to talk about ruptured cardiac hydatid cyst as a rare cause of systemic emboli.
Assalamu alaikum wa rahmatullahi wa barakatuh. Really, I'm happy to be here today, and I would like to thank the organizing committee for this nice arrangement. Actually, I was asked by many of our colleagues to represent this case again with more details, so I would like to give me a full opportunity to present the case, please. This is Mr. N. Mr. N, he's 31 years old, a Nepali patient. He was working at one of the shops nearby King Khalid Hospital, Ha'il Kingdom of Saudi Arabia. He brought with his friends to our ER and they found him collapsed at the toilet. Actually, this patient, upon arrival to the emergency department, he was flushed, cyanosed, not communicative, not obeying commands. Sooner, the patient developed skin rash, urticaria-like, puffy face, swollen lips, and his blood pressure was unrecordable. So, Code Blue announced in ER, and Code Blue team started to resuscitate the patient. They intubated, and then the patient invented, given adrenaline and noradrenaline, and then the patient finally shifted to the ICU. In the ICU, they requested for CT scan brain, and they requested for blood samples for toxicology and pan-septic screening. And actually, the blood samples for toxicology and pan-septic screening were negative. And the CT brain, there was no gross abnormalities in CT brain except, as you see, a small hypodense focal lesion in the left globe. It was consistent with possible foreign body. Actually, I received a call after 2 hours of the patient admission in ICU that Dr. Ihab, we have a patient like this, but
While we are doing assessment for the patient, we found that the distal pulses of the patient were not palpable, pedal pulses, I mean, and the patient extremities are cold, and we cannot record the oxygen saturation. So we went there and we assessed the patient, and we found that the distal pulses are not palpable, even the popliteal and even the femoral pulses are not there. Then the oxygen saturation was not recordable, and the distal extremities were cold, so we requested for CT angiography. As you see here, this is the abdominal aorta, and this is the post-iliac artery. There is total occlusion of the distal aorto-iliac vasculature. So we started to give the patient heparin, and we requested for cardiac assessment, and then we shifted the patient to OR for bilateral femoral embolectomy. After the procedure, what I would like to mention that we faced a little resistance while we are removing the emboli. And the surprise with the nature of the emboli, it was like a thick membranes, as you see. And we expected that we make like an intimal injury. So we asked the ICU team to keep an eye for the hemodynamics of the patient. And the emboli sent for histopathology examination. Post-operatively, the patient regained his distal perfusion, but 2 hours later, we received a second call from the same intensivist and for the same patient. That Dr. Ihab, now we started to reassess the patient again, and we found the left upper limb distal pulsations are not there, and the patient left upper limb is cold. So come please to assess the patient. We asked for duplex ultrasound that revealed the patient has brachial block. So we requested to shift the patient to OR for brachial embolectomy. The surprise was there is the same embolic materials that we removed from the femoral artery. It was the same from the brachial artery. It was the same nature of the embolic. Later, the same night, the general surgeon received a call from the intensivist that please, we have the patient like this, but now the patient abdomen is tense. There is tenderness of the right hepatic colonic flexure and left splenic flexure. So the general surgeons advised for double contrast CT. The double contrast CT was not consistent with superior mesenteric artery occlusion, nor definitive for bowel ischemia. But the next day, the patient abdomen became more tense with increased CK and worsening renal profile with low urine output and tender abdomen. So the general surgeon decided to operate upon him. And this is the picture intraoperatively. There was no anything abnormal except a small area of serosal injury in the proximal jejunum. So they decided to have a second look after 24 to 48 hours. And this is the second look. Second look was taken negative with no more serosal injury. With fallopian abdominal closure, patient shifted back to ICU. So we started to have a meeting. What are the possibilities? Going back to the history that the patient presented with anaphylaxis, and post-anaphylaxis, the patient have multiple ischemic events in different areas. So it may be ruptured hydatid cyst or ruptured cyst, intravascular, I mean. Or the second possibility, it was metastatizing atrial myxoma. So we asked for urgent cardiology review by a senior consultant. He came and he started to do transesophageal and transthoracic echo. And as you see here, there is a flap and remnants of a ruptured cyst in the left ventricle. So this is the main source of the emboli. You can see here, this is the echo live. You can see here the remnant or the flap of the ruptured cyst in the left ventricle.
The histopathology report was collected and was consistent with hydatid cyst. We started to give the patient anti-echinococcal chemotherapy, which is albendazole. Albendazole started. Patient was more stable and he started to off IV norepinephrine. He was on moderate ventilatory setting, start passing good volume of urine. He was conscious and then got extubated. Patient extubation, post-extubation, patient transferred to the surgical observation room. Fortunately, the patient survived. But there is still a question, and I would like to ask the floor about this. This is not the end of the story. Still, the patient is survived, but still we have a flap in the left ventricle. Is it to be excised, or we can continue with medical treatment? One minute. As I said, it is not the end of the story. We have questions. The flap inside the left ventricle, is it to be excised surgical by open heart surgery? Or we can continue with medical treatment and follow the patient by a frequent echocardiography. Actually, we communicated with the higher hospital in Faisal, and they are divided into two teams. Some they have opinion we should excise the lesion by open heart surgery. Why? They said that this lesion may interfere with the conductivity of the heart. It may affect the function of the ventricle, of the myocardium, and also it may recur again. It may adhere and make cyst again. So they requested to excise the other, like the parasitologist, they requested to follow the patient by medical treatment and then for frequent echocardiography to see if there is new evidence. We reviewed the literature and we didn't find any data that can support any of the two opinions. But unfortunately, the patient asked to seek second medical advice in his country, and he left the kingdom. Thank you.
Thank you, Dr. Ehab. Very nice case.
Now we will shift to Professor Dr. Maisa Abdul Wahab. She will talk to us about the association between pulsatile tinnitus and vascular disorders.
Thank you for all Egyptian Vascular Club, and thank you for all chairpersons and moderators, and thank you for all audience, and also thank you for Masr Al-Fim. I will present the association between pulsatile tinnitus and vascular disorders. The major arterial and venous structures of the head and the neck area in close contact with hypotympanum. The same bony palate over the internal carotid artery separates these vessels from the basal turn of cochlea. This image demonstrates and shows the anatomical relation between both internal carotid artery, internal jugular vein, especially superior bulb, and cochlea of inner ear. Normally, the blood stream is laminar and noiseless in blood vessels. The disturbances of laminar flow and the occurrence of turbulence may cause vessel wall vibration, which transmitted to the inner ear through the thin bone palate and result in audible sounds. Tinnitus is a perception of sound in the ear in the absence of the external stimulus. Only a small percentage, about 5 to 10% of tinnitus is pulsatile and defined as tinnitus that is rhythmic and synchronous with heartbeat. Pulsatile tinnitus caused by any disease of internal carotid artery, either atherosclerosis, stenosis, fibromuscular dysplasia, aberrant carotid artery, tortuous or internal carotid artery aneurysm, carotid body tumor, also rarely ectatic jugular vein. A pulsatile tinnitus may be the first, unusual, and sole manifestation of carotid artery atherosclerosis and stenosis. So, early screening and accurate diagnosis of atherosclerosis will prevent stroke and the other central nervous systemic manifestation. Atherosclerosis is not only cause of stenosis, but also cause endothelial dysfunction and the change in vascular compliance. The internal carotid artery, peak systolic velocity and end diastolic velocity values were significantly higher in patients where intimal medial thickness were greater than 1 millimeter and the lumen diameters were smaller. Some authors revealing that carotid artery atherosclerosis account for 15 of review of 100 cases of pulsatile tinnitus. In another study, mild to severe carotid artery stenosis was the cause of pulsatile tinnitus in 24 cases of 145 patients with pulsatile tinnitus. In the survey carried by some authors, the records of 84 patients with pulsatile tinnitus were reviewed. Internal carotid artery stenosis in 20% and atherosclerosis of internal carotid artery in 8%. The result of different trials demonstrate the pulsatile tinnitus has been treated by carotid intervention is a successful beneficial therapy in symptomatic patients with greater than 70% carotid stenosis. This image shows color duplex ultrasound adherent atheroma, which causes 70% stenosis and nausea appearance in the right side of the show, which cause noises and pulsatile tinnitus. There are reports of symptomatic venous hum in the medical literature dating back to 1961. In a study on 30 cases of pulsatile venous tinnitus and in 3 patients, he ligated the internal jugular vein. The hum disappearance temporarily in 2 and permanently in 1. Some authors in separate case reports noted the disappearance of the venous hum with pressure over the internal jugular vein and reported that ligation of the internal jugular vein in their patients cured the symptoms. The pulsatile tinnitus in patients with high jugular bulb disappears when the internal jugular vein is compressed and occluded. This is documented by applying gentle pressure over the vein during duplex imaging and having the patient report the disappearance of Perway as soon as the internal jugular vein is seen to collapse and reappear when the vein expands. Patient reported that the Perway is more at night. In this image, show the normal flow of the venous circulation in the internal jugular vein. If the internal jugular vein ligated below the common facial vein, the clinical symptoms do not appear. Case presentation. Female patient 39 years old admitted in our vascular surgery department at Al Zahra University Hospital in February 2021. The patient presented with pulsatile tinnitus in the left ear 7 years ago, gradually onset and slowly progressive course, which increased during sleep and at night. All otolaryngal investigations were done and failed the normal study. The patient was advised to consult vascular surgeon who discovered ectatic left jugular bulb superior left jugular bulb after duplex ultrasound and CT angiogram. This is the duplex ultrasound. This is the angiogram, which show superior bulb of in internal jugular vein in left side, more ectatic. Ligation of the internal jugular vein above facial vein and the below jugular bulb was done. Post-operative, the patient improved and the tinnitus was disappeared completely. This is in the operation before and after ligation of superior bulb of internal jugular vein. This image shows the patient 2 months post-operatively. The patient comes to our vascular surgery and thanks to all the doctors in the department. Thank you.
Thank you, Professor Dr. Maisa. Very nice presentation. To save time, 1 question for each speaker. Dr. Ala Sharabi. Any question for Dr. Ala Sharabi? Okay. Dr. Hani Abdel Mu'min. Any question? تفضل.
بس بالنسبه للبيسد ديزيز احنا بنبقى كونفرونتد ببيسد ديزيز في ديب فينس ثرومبوزس وسوبرفيشال ثرومبوفليبايتس، لكن هو المشكله بتاعته اكبر من كده، ومعظم العيانين بيبقوا او عيانين كتير بيحصل ليهم بلايندنس، ممكن يبقى العيان يحصل له ديس من رابشرد اورتيك انيوريزم او حاجه في البلمونري ارتري. فمهم جدا ان احنا يعني لما يجي لنا عيان عنده ديب فينس ثرومبوز او سوبرفيشال ثرومبوفليبايتس لازم العيان ده يروح له اوفثالمولوجيست كويس عشان يشوف لو هو عنده مشكله، لان في حاجات بتستخدم دلوقتي وفي دراجز زي الفليكسيماب والحاجات الازاثيوبرين بتقلل جدا موضوع البلايندنس بيحصل من البيسد ديزيز. وممكن طبعا العيانين دول نعمل لهم سيرفي على الاورطه والبلمونري ارتري. ده كومنت كنت عايز اقوله.
شكرا دكتور عصام. ده
هو
كومنت مش سؤال يا دكتور. اتفضل
تمام.
دكتور
هو
هاني.
بالنسبه انا ما خدتش التايم بتاعي في المانجمنت عموما، لكن احنا عندنا دايما رول بنتكلم فيه ان البيس ديزيز ده هايبر انفلاماتوري ريسبونس مور ذان فاسكولار افكشن. يعني الحاجه الثانيه الاولانيه احنا عندنا ستاندرد ريجيمن ان احنا بنمشي على الكولشيسين اولا كورتيكوستيرويد. اف اني ريزيستنس بنبتدي ندي العيان حاجه اسمها داماردز اللي هي ديزيز موديفاينج انتي ريوماتيك دراجز. داماردز دي نوعين منها كونفنشنال اللي بيتكلم عليه الدكتور، اللي هو زي مثلا الاذاسايوبرين سايكلوفوسامايد الحاجات دي كلها. الحاجات الحديثه اللي بيتكلم عليها اسمها ايروتوكسيماب او اسمها البيولوجيكال دامارد اللي هي روتوكسيماب والتوسيليزوماب الاكتيمرا الحاجات دي كلها. ده اللاست لاين اوف ديفense ان بيس ديزيز. ماشي.
شكرا تاني. هو الدكتور عثمان اتفضل.
بالنسبه للباست يعني احنا عيبنا ان احنا ما دو نوت كوميونيكيت. احنا عندنا في القصر العيني كانت عمل لفتره طويله دراسات على العيانين بتوع الباست، ودرس الاميونولوجي في العيانين دول، واتعرف ان في جينيتك فاكتور موجود في العيانين دول الاتش ال اي سيستم
تمام
ريليتد للديزيز ريليتد للاتش ال اي، وان الديزيز ده اوتو اميون، وان حتى كان ابتدى يدرس الريليشن بتاعت الهيباتيتس لما كانت منتشره في مصر هنا اهو مع الباست. فالباست يعني في مصر هنا مش باست، ده حاجه اكبر بكتير من باست، ده بنسميها جوفينايل ارترايتس او اوتو اميون ارترايتس. في بعض العيانين بيبقوا باست وبعضهم ما بيبقوش باست، فالموضوع اكبر بكتير جدا من كلمه باست في مصر بالذات. يعني يمكن 20% of our patients اللي هو الاسكيميا هم اوتو اميون ارترايتس. للاسف يعني احنا ما عندناش شغل بيستمر وبيبقى ساينتفك ويوصل للنهايه. يا ريت حد من الشباب يتولى هذه الحالات ويدرس لها الاميونولوجي بتاعها ويشوف الاتش ال اي سيستم ويشوف الاب تو ديت اميونولوجي ويعرفنا، لان ده هيساعدنا كتير جدا في علاج العيانين دول.
شكرا دكتور اشرف بيه على الاضافه في هذا المجال يعني. والدكتور محمد يحيى بريفريشن ابليشن كوتشن. دكتور محمد يحيى.
ممكن ماشي. دكتور هاني كنت عاوز اساله وبعدين اسال هو بس ملحوظه الدكتور هاني والفلور والشير بيرسون. we notice that the number of basic disease and Berger disease decreasing in Egypt in comparison to 20 years before. Do you have any explanation for this? يعني احنا at the beginning of my career كنا بنشوف حالات البرجر والحالات البيست دي كتير قوي يعني now every now and then على ما بنشوف حالة بيست او حالة
حضرتك انا رايي
فهل في explanation؟ هو الدكتور اشرف بيقول انها جينيتك ديزيز وكده، فهل المصريين اتغيروا ولا
ممكن حضرتك الابيوز اوف كورتيكوستيرويد؟
العيانين موجودين من زمان. انا رساله الدكتوراه بتاعتي انا كانت على الجوفينايل ارترايتس، وكان عدد العيانين زي ما بقول لك حوالي 20 to 30% of the patients ايام ما كنت انا نايب ارترايتس.
احنا كان عندنا الاسم لازم يبقى فيه عيان برجر او اتليست، لكن دلوقتي كل فين وفين
هو
على
مش
ما
بيزيدوا، هو احنا ما درسناهمش صح، ما عرفناش الديستريبيوشن بتاعهم. هم اساسا ايه البيكتشر بتاعت الاميونولوجي اللي موجوده فيها، ايه الانتيجين انتي بودي رياكشن اللي بيحصل لهم. احنا ابتدينا نفكر زي ما بقول لك في الهيباتيتس، ولقينا بعض الدلالات الهيباتيتس، يعني المصريين بيجي لهم هيباتيتس كتير، وفي ريليشن ما بين الهيباتيتس وما بين الارترايتس. هي المشكله ان ده انديميك ديزيز عندنا في مصر مش بيحصل، وما درسناه ووصلنا الى accurate conclusion للي بيحصل فيه.
تمام. دكتور بقى محمد يحيى.
one of the first medical school started the vascular medicine.
Yes. My question to Dr. Mohammed Yahya. Do you think the subfacial perforator ligation is still effective operation and you can do it easy, because most of those patients have lipodermatosclerosis and make the getter area is severely fibrosed and it's not easy to do it.
Thank you. Yes, I think it has a better result than the traditional surgery. But as regarding the new technology from the less invasive maneuvers as laser or radio frequency, also I'd like to share that the last conclusion, many trials are now talking about the trans ultrasound guided sclerotherapy and foam sclerotherapy, just to start first by the sclerotherapy, and then if fails, we shift to the minimally invasive maneuvers as laser and radio frequency. But now the combination between sclerotherapy and minimally invasive maneuvers, it's better and has a better result.
اتفضل.
دكتور محمد، الحقيقه احنا عملنا ريسيرش كتير على البرفوريتورز والليج السرز والفينوس ليج السرز يعني، وكانت المينيمال انفيسيف اللي هو الابليشن بليزر او براديو فريكونسي كانت الريزلتس بتاعتها افضل بكتير من السيرجري، على اساس ان السكن دايما بيبقى فيه هايبر بيجمنتيشن وبيبقى ديرماتوسكليروزس، واي انسيجن فيه بيعمل ري السريشن اجين. لكن في برضه اللي هو الجزء اللي انت قلت عليه ده اللي هو الدوبلكس جايدد فوم سكليروثيرابي برضه از افكتيف از مع عدم وجود اللي هو السافنس نيرف انجن، ده احيانا بيحصل كتير مع الثيرمال ابليشن. مش عارف، احنا عملنا يعني دراسه كبيره عن الموضوع ده.
هو الميتا اناليسيس حضرتك في الاخر خالص قالت انه افضل نبدا بالكيموثيرابي بالسكيلوثيرابي، ولو we have insufficient